morning students. Today we are going to discuss the femur bone. So this is the femur bone. This is the longest and strongest bone. This bone has upper end, it has lower end and shaft. Now to determine the side of this bone, the head of the bone is directed superiorly and the shaft is convex forward. Now coming to its anatomical position, that how it is placed in the body. The head of the femur is directed upward, forward and medially. You can rotate it like this. The shaft is vertically, you can say it is vertically placed and its convex anterior surface is there. Then both the condyles, they touch the horizontal plane. So this is how it is placed. The another way of is, if you hold the bone like this, so this is the anatomical position of the bone. Now coming to the description of the bone, as I have told you, it has upper end. Now this upper end has different parts. What are those? It has a, you can say a spherical head which is going to articulate with the acetabulum of the hip bone to form the hip joint. Then it has neck portion. This is the neck portion and there are two elevations. One is this greater trochanter and another is the lesser trochanter which is placed posteriorly. So these are the four parts. Now coming to the description of the head first. It is more than, you can say more than half of a sphere. And this structure is more than half of a sphere which fits itself into the acetabulum of the hip bone to form the hip joint. Now if we see just below the center of this head, there is a pit which is known as the fovea. This fovea is going to give attachment to the round ligament or ligament of teres. So ligament of teres is attached here. Now this portion is the neck portion. Now neck has two surfaces. One is this anterior surface which is facing anteriorly. Another is the posterior surface. And it has two borders. One is this superior border and another is this inferior border. This superior border is concave. You can see here. This is concave and horizontally placed. And this is straight but obliquely placed. You can see here. It is going downward. Now this is the greater trochanter. This greater trochanter has, if we describe the greater trochanter, it has anterior surface, it has medial surface, lateral surface and it has medial surface which is towards this neck portion. So lateral surface, medial surface and anterior surface, and it has one border which is known as the superior border. There is projection from the, you can say posterior superior part of this border. So that is known as the tip of that border or apex of that border. Now this neck is joined to the shaft, you can see here, by a line which is known as the intertrochanteric line. So this intertrochanteric line is the joining point between the neck and shaft, and if we trace the intertrochanteric line downward, it continues with a spiral line. You can see here, so this is the spiral line. So this spiral line above, it is continuing with the intertrochanteric line. And posteriorly, this neck is connected with the shaft through a crest. You can see this is the bony crest. So this is known as the intertrochanteric crest. Why intertrochanteric word is used? Because this line and crest, they are extending between the greater and lesser tubercles or trochanters. Now on this intertrochanteric crest, you can see an elevation over here which is known as the quadrate tubercle. So if we see the attachment on this portion, intertrochanteric line, is giving attachment to the capsular ligament. Means anteriorly, this whole of the neck is intracapsular. And posteriorly, this capsule is attached just, you can say, medial 3/4 portion, just above the intertrochanteric crest. This medial 2/3 portion of the neck is intracapsular. The rest of the portion is extracapsular. Now coming to the attachment on this greater trochanter, on the anterior surface, the gluteus minimus muscle is inserted, and on the lateral side there is an oblique line you can see here. So this is giving attachment to the gluteus medius, that is insertion again. On the medial surface of this greater trochanter, that is on this lateral surface, I told you this is the gluteus medius, but on the medial side, so on the medial side above this portion is the rough one. You can see this is the rough portion and there is one fossa over here, depression is there. This is known as the trochanteric fossa. Now to the rough impression, the obturator internus with two gemelli, that is attached. This is one thing. And to the trochanteric fossa, this is the obturator externus which is attached. So these are the attachment of the greater trochanter. Now coming to this you can say this apex of this superior border is giving attachment to the piriformis. Now coming to this crest portion, I told you on the crest there is a tubercle which is known as the quadrate tubercle. To this quadrate tubercle, the quadratus muscle is inserted over here. So quadratus femoris muscle is attached over here. Now coming to the lesser trochanter. So this is the lesser trochanter. To the lesser trochanter, iliacus and psoas major muscle, they are attached. So these are the different attachment on the upper part. Now coming to the description of the shaft. Shaft is more or less cylindrical in shape. So for description purpose, we divide the shaft into three parts, that is upper 1/3, middle 1/3 and lower 1/3. First we will describe the middle 1/3. In the middle 1/3 there are three borders. I told you this is on the medial side. So it has medial border, it has lateral border and it has one posterior border. You can see a thick posterior border is lying here. This thick posterior border is known as the linea aspera. Now coming to this, accordingly if the three borders are there, definitely between the lateral border and medial border, this is the anterior surface. Between the linea aspera and lateral border, this is the lateral surface. Between the linea aspera and medial border, this is the medial surface. So middle 1/3 has three borders and three surfaces. What are the border? Lateral border, medial border and posterior border or linea aspera. It has three surfaces, that is anterior surface, lateral surface and medial surface. Now as we go upward, if we see the lower end of this portion is expanded, and in the description of the upper 1/3 of the shaft, if we see this linea aspera, it diverges. So the diverging of the linea aspera is happening in the upper portion. So by this what happens, that it encloses another surface, that is the posterior surface. So same thing, it has lateral border, it has medial border, but posteriorly if we see, it has one line, I told you spiral line is there. That spiral line is continuing with the intertrochanteric line. So spiral line is there, and laterally there is a lateral lip of one tuberosity is present, which is known as the gluteal tuberosity. So what are the different lines? I repeat. So the lateral border, then there is the medial border, posteriorly there is the spiral line, and there is the lateral lip of gluteal tuberosity. So as the diverging of the linea aspera is happening, so four surfaces are there, anterior surface, medial surface, lateral surface and posterior surface. So I will describe the surfaces again. Between lateral and medial border, there is anterior surface. Between the lateral lip of the gluteal tuberosity and the lateral border, this is the lateral surface. Between the spiral line and the lateral lip of gluteal tuberosity, this is the posterior surface. And between the spiral line and the medial border, this is the medial surface. So there are four surfaces in the upper portion. Same story, it happens in the lower portion. So again you can see the linea aspera is diverging downward. So as it is diverging downward, it is enclosing again the four surfaces. So additional surface is enclosed between these diverged lines. So these diverged lines are given the name supracondylar lines. Why they are given the name supracondylars? Because they are lying above the condyles. So it then encloses another surface, which is the popliteal surface. So if we see, there is the anterior surface, there is the lateral surface, there is the popliteal surface, but the medial surface in this case is present only in the upper portion. Why? Because in the lower part, the medial border is just merging with the medial supracondylar line. So once it is merging with that, it is just obliterating the medial surface. So in the lower 1/3, the medial surface is visible in the upper portion only. In the lower portion, because of the fusion of the medial border and the medial supracondylar line, that medial surface it obliterates. So in the lower portion again the four surfaces there, but in the lowermost portion only three surfaces are there. So this is again the description of this shaft. Now coming to the lower end. Now this is the lower end. Lower end has two condyles, you can see. On the lateral side, this portion is given the name lateral condyle, and this is the medial condyle. Now if you see, this lateral condyle is more in line with the shaft. So the weight bearing, basically the transmission of the weight is happening from the shaft to the lateral condyle. So it is in line with this, and it is broader. You can see it is larger one in comparison to the medial condyle. Now, if we see the lower end, this is the lower end. The lower end has condyles and it has two articulating surfaces. What are those? You can see the smooth surface over here. This is one surface, which is the anterior surface, but articulating. Articulating means it is just making an articulation with another bone. So which bone is going to articulate here? Patella. So patella is articulating here. So this surface is known as the patellar surface. So these condyles are resting on the tibia. So this portion is known as the tibial articulating surface. Now this patellar articulating surface, you can see, if you see the close link of that, the medial part of this is longer. The medial part of this patellar surface is longer in comparison to the lateral one. And if we see the tibial surface is, it is larger. That is, lateral condyle is larger. So this is the larger articulating surface. But this medial surface, that is medial condyle, on the medial condyle, it shows the convexity which is towards the medial side. As this is the medial condyle, this tibial surface is more convex in comparison to the lateral surface because it has to articulate with the condyles of the tibia. Now coming to the description of the condyle separately. Now this is the lateral condyle. On the lateral condyle there is another elevation. You can see the bony prominence over here. This is epicondyle. So as it is present on the lateral condyle, this is known as the lateral epicondyle. Beneath this condyle, you can see a groove over here. So this groove is, you can say, deeper in the anterior portion and shallow posteriorly. So it is, deeper portion is giving, you can say, to the origin to the popliteus muscle, and the shallow portion is giving rest to the tendon of popliteus. So this is how it is present. Attachment of the popliteus muscle is there. So popliteus is related over here. Now just posterior to this is the lateral epicondyle. Behind this, there is a facet, you can see. So this facet is for lateral head of gastrocnemius. So lateral head of gastrocnemius is arising from this portion. So part of it is also arising from the lateral supracondylar line. And above portion, the upper portion of the lateral supracondylar line is giving origin to the plantaris muscle. So plantaris, lateral head of gastrocnemius, part of it is getting origin from this facet which is present posterior superior to this epicondyle. Beneath this groove, there is a popliteal muscle attachment is there, and this groove posteriorly is giving rest to the tendon of popliteus. Now coming to the medial condyle, again the same story. So this hole is the medial condyle. Sharp bony prominence over here is known as the medial epicondyle. So just behind it, just posterior to it, there is one tubercle which is present on this medial supracondylar line. This is given the name adductor tubercle. Why it is given the name adductor tubercle? Because the ischial fibers of adductor magnus, they are attached to this adductor tubercle. And another important significance of this adductor tubercle is this, that epiphyseal line of the lower end is passing through this adductor tubercle. This is very important. So it is giving attachment to this. And behind this supracondylar line or facet behind this medial epicondyle, it is giving origin to the medial head of the gastrocnemius. So medial head of gastrocnemius is arising from this portion. Lateral head is arising from the lateral supracondylar line and facet on behind this. So these are the important muscles which are arising here. Now this articulating surface, if we follow it posteriorly, you can see a notch present between the condyle. So this is known as the intercondylar notch. Now this intercondylar notch is anteriorly is bounded by the patellar surface. So this is the patellar surface, and part of it is bounding, just bounded here. So this is the posterior limit of the patellar surface, and posteriorly this is the intertrochanteric line which separate it. So this is known as the intercondylar fossa. Now to this intercondylar fossa, what are the important structure attached here? That is the cruciate ligament of the knee joint. Now anterior cruciate ligament is attached on the lateral epicondyle. So we will say, that is, it is present on the medial side of lateral condyle. So this is the lateral side of lateral condyle, this is the medial side. So medial side but posteriorly. So there is a smooth area which is giving attachment to the anterior cruciate ligament. And posterior cruciate ligament is attached to the medial condyle, but which surface? That is lateral surface of the medial condyle. Which part? That is the anterior part. Anteriorly there is a smooth. So anterior part of the lateral surface of the medial condyle is giving attachment to the posterior cruciate ligament. Posterior part of the medial surface of lateral condyle is giving attachment to the anterior cruciate ligament. Now this is all about the description of the bone. Now what we are left with, that is attachment on the shaft. For your convenience, I have written the things on the board. So what are the important structures which are present or related to the shaft is, first is the upper 3/4 portion of the, this is the shaft portion, upper 3/4 portion of the anterior and lateral surface is giving origin to the fibers of vastus intermedius. So vastus intermedius is attached over here, and in the lower part of the anterior surface, this portion is giving attachment to the articularis genu muscle. Clear? And there is one part that is line extending from the lesser trochanter to the linea aspera. Now you can see this is the linea aspera, this is lesser trochanter. So line extending here. So this part is giving attachment to the pectineus muscle. So it is the insertion of the pectineus muscle. So that is important. Then is to the linea aspera. What are the different muscles? That is very important viva question. So what are the structures attached to the linea aspera? Now from lateral to medial side. From lateral to medial side. What are the structure attached to it? That is vastus intermedius. Clear? Then comes the vastus lateralis. Then comes the short head of the bicep femoris. Then comes the adductor magnus. Then comes the adductor brevis. Then comes the adductor longus. Then comes the vastus medialis. So this is the arrangement of the muscle from lateral to medial side on linea aspera with slight extension upward and downward. So downward and upward, the extension of these muscle fiber is there. As I have told you that to the adductor tubercle ischial head of adductor magnus is attached. So definitely the adductor magnus which is attached, this adductor magnus which is attached to the linea aspera, part of it is extending to the adductor tubercle. Same thing is with the short head of the bicep femoris, it is just extending upward. Then same is vastus intermedius and vastus lateralis, and this is the vastus medialis. Now if we trace the fibers, this is the intertrochanteric line. To the upper portion of the intertrochanteric line, so it's a lateral side of the bone, vastus lateralis fibers, they go like this and they are just going downward and going to this portion, to the linea aspera. This is how the extension is happening. To the lower portion of the intertrochanteric line, vastus medialis fibers, they go like this, going towards the linea aspera. But I have made this list because this is very important questions for viva question, that what are the important structures attached to the linea aspera. And the other structures which are attached, if we just discuss the intertrochanteric line only, if somebody asks you that what are the structures attached to the intertrochanteric line, so I told you in the upper part vastus lateralis, in the lower part vastus medialis, and to the upper and lower end there is the iliofemoral ligament is attached over here. Y-shaped iliofemoral ligament is attached, and moreover important structure is the capsule of the hip joint is attached to the intertrochanteric line. So these are the attachment. So other structures, important structures other than these muscular attachment is which are attached to the linea aspera is medial and lateral intermuscular septa. So medial and lateral intermuscular septa, they are attached to the linea aspera, extending downward up to the supracondylar lines. So these intermuscular septi, they basically separate or divide the thigh portion into different compartments. That is anterior compartment, medial compartment and posterior compartment. So these intermuscular septi, they are attached to the linea aspera other than these muscular attachments. So this is all about the attachment of the femur bone. Now coming to the ossification part. Now femur ossifies from one primary center and 4 secondary centers. Primary center, as I have told you, it is always for the shaft. It appears by the age of 7th week of intrauterine life, and the neck is included in this. That is, neck develops from this primary portion only. So the center for the neck is basically it is the primary center only, and it just develop along with the shaft. Now the secondary center is one for the lower end. It appears by the age of 9th month of intrauterine life. So 9th month of intrauterine life, at that time the one center appear for the lower end. And for the upper end, there are three secondary center, one for head, one for greater trochanter, one for lesser trochanter. For the head portion, it develops by the age of 6 months of life, means after birth. 6 months of life, that is after birth. And greater trochanter, it appears by the age of 4 years. And for the lesser trochanter, it appears by the age of 12 years. And the fusion of these center is happening. So there are two epiphyseal centers. So those epiphyseal lines, they just fuses in, you can say, sequence, lesser trochanter, greater trochanter, and head. So first the lesser will fuse with greater, then greater will fuse with head portion. So these upper end, and that is once they fuses with each other, they fuses with the shaft by the age of 18 years. And lower end, it fuses by the age of 20 years. So lower end is the growing end of the bone. And what is the blood supply of this femur bone? It is by the perforating arteries. So mostly it is the second perforating artery, but sometimes the contribution from the first and third perforating artery, it happens, and that artery enter through the nutrient foramen. You can see this nutrient foramen is present in the you can say in the upper part of this shaft portion, but medial to the linea aspera. And the direction of the foramen is upward. So opposite to that is the growing end of the bone. Now there are certain important points which are related with femur. So they are related with femur. What are those? One important point is the epiphyseal line. It passes through the adductor tubercle. That is important, I told you. Second is, as I have told you, that this secondary center for the lower end, it appears by the age of 9th month of intrauterine life. Suppose if the child is born dead, so always be suspicious, because the child has the capability, or you can say, to survive independently. So that is the medical legal importance. If the child is born dead or stillbirth is there, so always inquire about that whether it is a natural one or it is kind of murder. So that is medical legal importance of the lower end. Then next important thing is you can say the fracture neck of the femur. It is very common in old age. So this is very important. And Pott's fracture is, that is tuberculosis of the leg bone. That is very common. The fracture in that case is there. That is between 40 to 60. And less than 40, you can see the spiral fracture of the femur. They are very common. So these are the certain applied aspects of the femur, so that you should know. So I hope femur bone is very much clear to you. So you should know the side determination, you should know the different parts of this bone, and you are supposed to describe the bone in different components, that is upper end, lower end, and shaft. So individually you can describe it. So if you like my channel, kindly like it, share it, and subscribe it. Thank you very much.